to wish to speak in this debate that they should bob. The question is that this House has considered the potential merits of a national eye health strategy. Dr. Rupa Huq.
Mrs. Harris, it's a pleasure to serve under your chairmanship, and I must congratulate my honourable friend for a really stunning speech and for scoring the debate on such an important subject, because visual impairment is in many ways illustrative of so many of the problems the wider NHS faces, but it's often under-acknowledged and, it doesn't go noticed. And the Minister knows, because he and I were in my adjournment debate on Monday. I went through a lot of documents, our local ICB one, local council ones, on the NHS, and eye disease didn't seem to be anywhere in them. I was sort of scouring. So it does tend to fall off. And as my honourable friend gave those very powerful statistics, 2 million people today living in this country with sight loss. It's expected to be 2.7 million by 2030, and by 2050, 4 million. Really powerful figures that she gave us. 600,000 people with age-related macular degeneration. Every 6 minutes, someone is told they're going blind. Every day, 250 people start to lose their sight in the UK. And as I say, some of these problems are sort of intrinsic to all sorts of things in our health service. The lack of joined-upness that she talked about between primary and secondary care. The fact that services are, she said, a postcode lottery. And the pre-existing backlogs, they were always there, worsened by COVID. And it's an unusual one because ophthalmology, with 11 million outpatient appointments a year, makes it the biggest outpatient speciality in the NHS. Yet, it is forgotten. It's a bit of a Cinderella service often. And locally, diabetic eye disease, glaucoma, age-related macular degeneration are all very big issues. I know that in Ealing, type 2 diabetes is suffered 3.5 times more amongst BAME populations than the wider population at large. Diabetes in our borough is very big, 8.4%, and in Harrow next door, even bigger, nearly 1 in 10, 9.5%. And diabetic eye disease is something that comes as a consequence of that, and it's sight-threatening, as my honourable friend said. And the odd thing is at primary level, optometry is private practice. So Specsavers, she mentioned, I think are the biggest providers in the country. They sent us all a briefing. There's Boots. If you're in Ealing, there's also great local independents like Eyes on the Common and Hines opticians. But then you've got the hospitals. So there seems to be a mismatch as well with the eye hospitals. And I was lucky enough to go to Central Middlesex recently and be shown around the eye department there. I also went to Western Eye Hospital myself, to the A&E bit of it. It's like A&E for eyes last year when I had shingles. And so that was interesting to see. It was a very long wait for half a day, on the weekend. They were very good. But I'm sure we could join up all these things better because there feels to be a disconnect. Things like referrals. So that's why I support, and I'm also signatory to my honourable friend's bill, having a national eye strategy. This would be crucial to reversing the situation that's seen eye care become this Cinderella service. So it was a step forward when the first ever National Clinical Director for Eye Care, Louisa Wickham, was appointed last year. But unlike some of those other big issues, on Monday we were talking about mental health, dementia, cardiovascular, heart issues, there is no national plan for eye care. And it's hit and miss, as my honourable friend says, and the lockdowns have just exacerbated all those waiting lists. And I wanted to just flag the work of my constituent, Judith Potts. She, for 7 years, has been a one-man band with her charity Esme's Umbrella, looking at the unusual, well, actually, it's more prevalent than we think, Charles Bonnet syndrome. So this is a disease that comes as a result of, it comes for people who are losing their sight, and they see very vivid hallucinations of often quite specific images. It can be sort of swirly patterns, shapes, those kind of things. And then also it can be gargoyles, World War I soldiers, boys in sailor suits. When this was being described to me, I'd never heard anything like it. Twice we've had receptions, I think just across there in the Jubilee Room for her charity. It's now becoming constituted as a proper charity. Esme's umbrella. It's her mother who suffered it, Esme. And she has managed to persuade the World Health Organization to recognise it as a condition, ICD-11 in their speak. But still, there's no training for it at medical school. No medical students get any training in it at all. It's seen as a sort of side effect of sight loss. It's estimated that a six-figure number of people suffer from it. I think some estimates say it could be 1 million people in this country. But, you know, they think they're going a bit, you know, they think it's a... people don't even know what to Google because it's so unheard of. So there are no pathways, there's no magic pill that can make it disappear. Most people have never heard of it. So I think more research is needed here to cure it and to cope with it. So there is a job to be done here. And actually, Coronation Street has had a big role. The actor Richard Hawley, who was at our last reception we did in the autumn, I think my honourable friend was there as well. The character Johnny Connor was a sufferer of... So that's done something to put it on the map. But still, I would, appeal to the Minister to have as part of a comprehensive eye strategy, to recognise Charles Bonnet syndrome. So proper research needs to be funded, and, you know, the trustees of the Esme's Umbrella charity, as it's now been constituted, are very respected people from Great Ormond Street, Moorfields, the Francis Crick Institute. They're all top consultants, but because it's not a recognised thing, they have to do the research on the side. It's not a satisfactory thing. So, you know, we need to persuade people, take them with us, and fund the proper research. Just a couple of other things I wanted to mention. This March, Health Service Journal reported a survey carried out by the Royal College of Ophthalmology. They found that independent providers, and my honourable friend referred to it too, are having a negative effect on patient care. Because, and I mentioned this a bit on Monday as well, so forgive me if it's a déjà vu, but patient choice sounds good, and we do have backlogs that need clearing. But then what ends up happening is that the independent sector creams off all the cutting cataract waiting list stuff, which is low-risk routine work. And actually, I have to say, the patients are usually a majority white population. And then when, you know, they could also do outpatient appointments, all the follow-up stuff. And the NHS is left with serious and costly cases of high complexity that leaves patients, typically BAME ones, I have to say, at risk of going blind. And the Royal College found significant staff shortages in NHS ophthalmology capacity. That's set to worsen in coming years unless immediate action is taken. 76%, that's over two-thirds of NHSR units in the UK, don't even have the correct consultants to meet current demand. 80% have become more reliant in the past 12 months on non-medical or allied professionals. So, you know, the capacity is missing there. The equation's gone all wrong. 25% of consultants are planning to leave the ophthalmology workforce in the next 5 years. That's for things like retirement as well. But you've also got a mismatch of doctors who are being trained in hospitals when the easy cataract stuff is gone. They're meant to get their teeth into that first and then do the complex stuff. It's all gone the wrong way. So there's a training issue. There's sustainability of the NHS. So tackling the backlogs is a priority, but so is sustainability and training in our health service. So Dr. Evelyn Mensah, inspirational woman at Central Middlesex, she argues that the status quo at the moment is leading to the destabilisation of hospital services. And this sort of inequity that's flowed means that the very foundational principles of the NHS being launched in 1948, the whole point that it's free at the point of need, has gone wrong. Because if you've got the easy stuff, you'll be dealt with. If you've got the sight-threatening, dangerous stuff, you languish. She says the direction of travel towards the private sector ISTOs, as opposed to resourcing and supporting the NHS, is undermining our comprehensive free service and will exacerbate inequality. And she asks for additional funding to support independent recovery, as right now, we've seen how these private providers cherry-pick the low-risk cataract work, and people are in danger of going blind if they're not seen in time. You know, these are very uncomfortable procedures with a delicate eyeball that's susceptible to discomfort and infection. So, you know, we need to save sight as well as the low-risk stuff. So from a business point of view as well, business case, it's not good value to the taxpayer. We need to do both. The College of Optometrists argued for more mixed mode referrals because there's record numbers with this surgical backlog. But people think of surgeries where people are waiting. There's also outpatient delays. So glaucoma reviews, medical retina reviews, all the follow-up stuff. And things like glaucoma, it's a silent disease, so it's easy to delay these things, put them off forever and ever. And people's sight is threatened. So, you know, we can't postpone these things forever. So we need to spread the load. And the whole point of ICBs is they are meant to be integrated care. So let's, you know, share the load with proper guidance. In an ideal world, the work would be shared out, it would be universal, standardised, consistent, there'd be data sharing, so all these systems are joined up at the touch of a button. And we could deliver eye care in a modern way, working together and contributing to the system. Joy Hines from Hines Opticians in Northfields Avenue said to me, I'd like to understand why the urgency for controlling our increasing numbers of myopic patients is not being taken seriously. The government has no strategy for prevention of this myopic epidemic. Myopia sadly leads to blindness, and that is itself a problem with scant resource. Understanding the gravity of the situation would be, we've been running a specialist myopia management clinic, but it shouldn't be the domain of the well-off. It should be available to every myopic child. So we can't, in conclusion, Mrs. Harris, rewind the clock back to February 2020 overnight. But let's hope that the jolt of COVID is a wake-up call to connect all the different bits of community eye care, optometry and hospitals. Let's go for diversity and inclusion in the workplace as well as equality of outcomes. So we can join up these different systems and institute a national eye care strategy. I'm so proud of my honourable friend and her bill. So clear the backlog is only part of the picture. Let's go for a systematic approach with this national strategy so sight can be saved.